In the previous video on the sacral plexus, we were able to talk about the different branches of this plexus. In this video, we will talk about the remaining branches and some important clinical relevance. From our mnemonic, some Indian sellers pay properly. PAY stands for posterior femoral cutaneous nerve of the thigh. It leaves the pelvis through the greater sciatic foramen, entering the gluteal region inferiorly to the piriformis muscle. It descends deep to the gluteus maximus and runs down the back of the thigh to the knee. The nerve root of this nerve is S1, S2, and S3. It has no motor function. The sensory function of this nerve is that it innervates the skin on the posterior surface of the thigh and leg. Also, it innervates the skin of the perineum. The next branch is the pudendal nerve. This nerve leaves the pelvis through the greater sciatic foramen and then re-enters into the pelvis through the lesser sciatic foramen. It moves anterior-superiorly along the lateral wall of ischiorectal fossa and terminates by dividing into several branches. The root of this nerve is S2, S3, and S4. As for the motor functions, it innervates the skeletal muscles in the perineum, the external urethral sphincter, the external anal sphincter, and the levator ani. The sensory functions of this nerve is that it innervates the P structure and the clitoris. We all know what P structure stands here, right? Also, it innervates most of the skin of the perineum. For easy remembering of the functions of the pudendal nerve, we can say S2, S3, and S4 keeps poo off the floor, because if the pudendal nerve loses its function, we will definitely see poo on the floor. Let's look at some other branches of the sacral plexus. In addition to the 5 major branches of the sacral plexus, there are a number of smaller branches. This happens to be the nerves that directly supplies the muscles, apart from the perforating cutaneous nerve which supplies the skin over the inferior gluteal region, and the pelvic splanchnic nerve which innervates the abdominal viscera. These other branches of the sacral plexus are the nerve to the piriformis, the nerve to the obturator internus, and the nerve to the quadratus femoris. An important clinical relevance of the sacral plexus is the lumbosacral plexopathy. A lumbosacral plexopathy is a disorder affecting either the lumbar or sacral plexus. They are rare syndromes which is as a result of damage of the nerve bundles. A plexopathy is suspected if the symptoms cannot be localized to a single nerve. Patients may complain of neuropathic pains, numbness or weakness, and wasting of muscles. One of the main causes of lumbosacral plexopathy is diabetic amyotrophy, which is also known as lumbosacral radioplexus neurophage. In this condition, the high blood sugar levels damages the nerves. Idiopathic plexopathy is another cause, being the lumbosacral equivalent of Parsonage Turner syndrome, which affects the brachial plexus. You might as well check out the video on the lesion of the brachial plexus in order to have a better understanding of the Parsonage Turner syndrome. Tumors and other local inversions can cause the plexopathy due to the compression of the plexus. As for the treatment of this condition, it is dependent on what is causing the symptoms. For tumors, space-occupying lesions should be removed if possible. For diabetic and idiopathic causes, treatment with high dose of corticosteroids can be useful. In our next video, we will discuss the sciatic nerve in details. Don't forget to subscribe and share. See you in the next video.